back here in office and in home office to chat a little bit more about mental health and mental wellness, in particular, the concept of depression. And I say concept because for many people, and Dr. Patino, you and I have discussed this a lot, depression is always listed as something like sadness. But on a clinical level, it's really something distinctly different. What is it to the layman?
Well, we depression is something that I like to say we should call it something else when we talk about depression as an illness, because the connection between depression and sadness is kind of difficult to separate.
Mm,
Because for some people, it feels the same way. But when we talk about depression as an illness, we're talking about something much more complicated. And you and I have discussed this article that was recently published in the UK about serotonin not being the cause of depression. Well, I mean, I was really amazed to hear that in a scientific paper because we've known for a long time that serotonin is not the cause of depression and that depression is a multifactorial issue that is quite complex. And we want to be simplistic and we say, why do we get depressed? It's probably because of two reasons. And we're going to try to kind of dissect both of them. But one of the reasons is that we are thinking and that we're animals, right? So we have the capability to experience depression, okay? And it gets very complicated when you get into the brain. So the whole idea of the chemical imbalance, right? And as you'll remember, back in the 80s and 90s, we used to tell people you have a chemical imbalance. That is not necessarily true because having low serotonin is not the cause of depression
mm.
because serotonin is all over the body. It's not just in the brain. So having low serotonin would have implications systemically, right? But serotonin is an important neurotransmitter, meaning it helps one cell talk to the other. That's all it does. It's a neurotransmitter, transmits neural communications between brain cells. And there's millions and millions of those. Now, when we talk about depression, though, as an illness, the symptoms of depression actually look very similar to hibernation, right? When
Mm.
bears go into hibernation, they sleep a lot, they're tired, their metabolism goes down, they don't have much of a need to eat. I mean, there's all kinds of stuff. So some people long time ago said, well, maybe it's a bizarre way of going into hibernation when there's not enough food outside, right? But it's a little more complicated than that. So there's been a lot of theories. There have been psychological theories, you know, your inability to manage negative thinking. There are cognitive theories. There are all kinds of different theories. At the end, every theory is a little piece of the puzzle, right?
Mm.
But it really, when you get biologically into the brain, is really a reaction of stress and cognition, meaning how do we connect our ability to cope with stress and why there's some vulnerable people that we fall into this depressive syndrome, right? And depressive syndrome meaning lack of energy, lack of motivation, lack of interest, difficulty sleeping, is sleeping too much, sleeping too little, eating too much, eating too little, feeling very negative about the world, right? And then we don't know how to, and you feel like that, right? Whether it's from external stress or from internal medical stress, then you have to find a way to cope. And that's the cognitive part. So the cognitive part gets very negative, right? There's a lot of negative reinforcement into everything is bad, if you may.
So why was serotonin the target? I mean, if you said it doesn't cause it, and we've known this for a while. Pretty much all the medications, and we mentioned this in the last show, are based on a theory from back in the 50s and 60s about these neurotransmitters. So why are we sticking with it? Why is it still something that's focused on?
Well, because it does help some people when you take medications that increase the availability of serotonin in the brain. to feel better, right?
Mm,
So the theory was that if you take something that increases serotonin in the brain, then serotonin must be the cause. Wrong,
gotcha.
right? So what happens is that is the logical, non-scientific explanation, right? But there are other motivations to the simplicity of the serotonin theory, and is that it's easily sold. If you're a pharmaceutical company, you can sell your product, okay, by connecting depression, serotonin. And actually, when actually this happened when Prozac came into the market in the United States, that was a big thing. Prozac was a big thing. Zoloft was a big thing, right? Uh, to the point that they started using it for all kinds of different things. And we have learned that depression is not a single factor illness and is not a single treatment illness, right?
So the pills alone are going to do it. They may help though, and that's where that, I guess, misunderstanding of correlation and causation that people kind of run with. And of course, there's the financial side of it. So if someone is diagnosed depressed or feeling depressed, they may take some of these SSRIs. Correct? Is that's the term for it to help
Yeah,
out?
yeah. But if you look at what does SSRI means, it means selective serotonin reuptake inhibitor. So what does it mean? There are receptors in the neuron for serotonin, like there are receptors for norepinephrine and other substances, right? So when you said it's a selective serotonin reuptake, it means it's blocking the reuptake pump to make more serotonin available in between two cells. That is actually that simplistic, right? And
Hmm.
by increasing the amount of serotonin between two cells, these two cells talk to each other better. That's it. But translate that into millions of times, right? So um, now that's not without consequence. When you increase serotonin, other things happen, right? So people sometimes become blunted. People will tell you, "I'm not depressed, but I'm totally indifferent." So that is a common side effect, the indifference, decreased sex drive, right? If you get too much serotonin, then you may get nauseated. You start vomiting.
Hmm.
You may get flushed. There's something called serotonin syndrome, where you have too much serotonin in the system. But why is it important that we move away from the idea that there's causation from serotonin and depression is that we keep pushing the envelope, right? We start managing a chemical instead of managing a life. So, I mean, I can tell like this morning, because I worked in the hospital, I had a 12, 13-year-old girl that comes into the hospital who's had problems with depression, probably bipolar depression for a long time, and comes in on 7 different medications, right?
Yikes.
None of the medications were at adequate doses. And that's a principle of pharmacology. Use one medication to efficacy or tolerability, and then if it doesn't work, try another one. Well, this kid was taking 4 SSRIs. 4 SSRIs. And I was there with my students and we were talking about this. So this came to mind. And I said, why? What is the purpose of this? None of the SSRIs were adequate doses, right? So undoing that takes time. So I had to get into the process of explaining to my students we're going to be taking these medications away and we're going to keep one and we're going to increase that one.
Hmm.
So take the other stuff away. But I can imagine somebody thinking, I'm going to tweak this a little bit here and I'm going to tweak that a little bit there. And this is going to be better for sleep. This is going to be better for energy. It's going to be better for motivation. And now all of a sudden you have a kid on 7 medications that, despite all of that, is
Still
in
have
the
depression.
hospital. It's in the hospital.
Yeah.
So again, the treatment of depression, we'll get back to that in a minute, is not about um, treating symptoms. It's about making people more functional and less of a danger to themselves, right, or other people. So we miss the forest for the trees, right? We start focusing on the wrong things, and we forget that there's a bigger picture. That's why it's important when we're treating people with depression to ask, how is this treatment improving your life?
Mm.
right? I mean, treating symptoms is not that complicated. Making people functional is complicated because requires a connection. It requires a partnership, right? And that becomes very important.
Well, you've said in the past when we've chatted that taking medication, or what you do is not to give treatments, is to offer options for people to choose. And in the area of the medication, I was quite literally editing a part of a book of ours concerning that. It's really about risk management, and balancing out the potential negative side effects with the how it's helping you to mitigate those symptoms so that you can address the other issues. And what are the basic side effects that you see? What are the most common that, and I know people are always scared to, hey, it's going to change me, it's going to do this, especially when it comes to children. How do you manage that when you're discussing it with a patient, particularly with a child?
Well, when you're dealing with kids and when you're dealing with parents, it becomes very important that you have a working idea of what you're dealing with, right? So let's take depression as an example, and uh, you have somebody that comes to you in acute state of sadness, irritability, frustration, difficulty sleeping, decreased appetite, losing weight. It's been going on for at least a couple of weeks, and now it's getting worse, right? And then you say, well, I need to understand how this person got from point A to point B.
The
I
movie.
mean, exactly. But we get back to the movie because I need to understand what kind of stressful events was this person exposed to. I need to know what kind of temperament the person has had before this happened, right? I need to know what is the family history, right? Is there a history in the family of major depression, bipolar disorder, history of schizophrenia? Mom had postpartum depression after the kid was born. I need to look at a number of different things. Then I have to look at if the patient has sustained trauma, right? Or the patient has been neglected, or if the patient has started experimenting with some drugs and alcohol,
Mm,
right? I have to look at has the patient had any medical illnesses like thyroid problems or cancer or leukemia or whatever. So people, when people get depressed, okay, we always look for an easy answer in a very complex situation. But if we want to provide options, I want to provide options biologically, psychologically, and socially. So all those factors that I mentioned before, temperament, personality, stressful situations, medical illnesses, drugs and alcohol, social isolation, loneliness, all those different things can be generators of depression. But it's never used like a single thing, right? So there are multiple factors. So if a patient comes to me with depression and I say, okay, there's you have a family history of depression. Yeah. This is not your first episode of depression. You have all of these symptoms. But by the way, you tell me that you feel neglected by your family. There's no recognition of your value as a human being, and you always become somewhat isolated, avoidant of social interaction. And then you're 13 years old and you already started experimenting a little bit with alcohol, stealing it from your parents, getting high on marijuana, right? And now you have all this anger toward your parents. So all of that together is depression. Okay. Now, when the parents tell me, well, can we treat this with medications? And I have to say, we can treat the symptoms associated with depression with medications. But there is not a single treatment for depression. So the idea that medications are the treatment of depression is a fallacy.
mm,
Just like saying that insulin is a treatment of diabetes. Insulin is a treatment of elevated blood sugar. The treatment of diabetes is very complex and involves your personality, your compliance, your exercise, your weight, your diet, all kinds of other things. The same thing happens with depression. So it's important to explain to the parents, even before you talk about side effects, you know, this medication may help your kid reduce the intensity of their symptoms, but the medication is not going to teach them anything. Now,
okay.
In terms of side effects, if we're talking about SSRIs like serotonin drugs, like we were mentioning before, excessive serotonin really it starts with side effects in the GI tract because there's a lot of serotonin in the GI tract. So you can feel nauseated when you start taking it. You may get loose stools. You may get some cramps in your stomach. You can get some sweating because of it. And you can get emotional bluntness. It's like
Mm.
you don't react as much to what's happening around you, right? Um, so it becomes very important to understand that we have to recognize that um, anything that causes stress can cause depression, but you have to have certain vulnerabilities. And you have to have, I mean, one of the questions we seldom ask is okay, so how come some people don't get depressed
Mm.
under severe circumstances, right? If you have two people exposed to the same stress, one gets depressed, the other one doesn't. What's the difference? It's those psychosocial factors and those biological factors like family history, temperament, experiences in childhood, you know, um, your own cognitive ways of perceiving yourself. So our response to stress is going to be different based on our life experiences, right?
So there's quite literally no way to generalize the treatment, as you said. Really, the SSRIs are simply for, or any medication, are simply to manage those um, the frequency, intensity, and the dysfunction, but then all the other stuff involved with it. One of our listeners just asked the question that you answered about can undertreated ADHD cause depression, and your answer was quite simply yes. And it seems to me that that's part of those stress factors that you're mentioning. What are the other stress factors that are typical with people that develop depression, truly clinical depression?
Well, let me just touch a little bit more on ADHD. The reason ADHD makes you vulnerable to depression is because you can't pay attention. So it's very difficult to develop adequate cognitive skills to deal with something in a little longer term. So the person with untreated ADHD is very impulsive. It's very reactive, and they're constantly being criticized because of their impulsivity. So they have to deal with a lot of rejection. That's where you get into temperamental issues and neglect issues, right? So it's very easy to neglect a kid with attention deficit disorder. But stressful events can be internal and external. So if we look at external events, the death of a family member, divorce, um, money problems, um, I don't know, domestic violence, anything that creates a sense of chronic stress that you don't feel cognitively able to manage is going to make you get into the bubble of misery, as we've talked before, right? You get into a place where you're comfortably miserable because you're not taking any risks.
Mm.
So one of the ways that people deal with depression and anxiety often is by isolating, right? And the isolation by itself perpetuates the depression and perpetuates the stress because on one hand you're safe but you're not content, right? So you feel the pressure to move out of the bubble, but at the same time you're too comfortable in the bubble. So that's why I tell people if you're depressed for a long time, it takes a little longer to get a hand that helps you pull out of that bubble of misery. So if you perceive somebody in that bubble, you're not only thinking, okay, well, how am I going to decrease their symptoms of depression, but how can I help that person feel more confident and stronger physically, okay, and rested enough to take the risks they need to take to be less depressed or to be less anxious, right? So and there's a direct relation between the internal stress that comes from either illness or just a basic reaction to stress in the chronic basis that does not allow the brain to actually repair itself properly.
Mm. Like
So we,
structurally, literally structurally, that you're saying.
yes, I mean
Wow.
we can get. I mean I don't want to get too scientific about this, but we can get into situations like cortisol level elevation that happens in most situations may lead to impact on reducing the efficacy of something called BDNF in the brain. It's called brain derived neurotrophic factor that helps the brain repair itself, right? So that's a simplistic one that is a lot more complicated than that. But that's why in psychiatry, we don't like stress because we don't like chronic elevations of cortisol because they perpetuate the problems.
Wow. So I've been told once back in the day that the medication, life is like putting a puzzle together. And if you have depression or some other mental illness, it's like trying to put that puzzle together while riding a roller coaster. And the medication is simply to help flatten out the roller coaster, but it still doesn't help you with the puzzle. So if we've got somebody on the proper dosages of whatever to manage those things, what are those next steps that are not medically or not pharmaceutically driven?
Going back to the example with insulin and diabetes, right? If you come to the office of an endocrinologist with blood sugars in the three or four hundreds, they put you on insulin, and um, you come back a week later and your blood sugar is still elevated, and you tell the doctor, well, the insulin doesn't work, doctor, right? So the doctor would obviously going to ask some questions like, have you changed your diet? Have you started exercising? Are you counting calories? See, you start looking at the changes that need to happen in the person's environment to de-stress and facilitate recovery, right? The same thing happens with depression. Uh, you can flatten the curve of the roller coaster, right, to some degree, but you don't want to make it so flat that the person loses motivation, right? Because life in general is not a flat line. It's a little bit of a roller coaster, not a very deep one or profound one, but you have to be able to allow yourself to take the risk of what's in front of you, right? Life. Because it's very easy to go into hibernation and avoid. So, what we're trying to help the person with by taking medications is to gain the strength to take risks again. What risk to start with? Life, right? And I always go back to the idea of the bubble of misery that is very comfortable but very dysfunctional. So when you tell people, you've been in the bubble of misery for a long time, and I give you the medications, and you have more energy, you're sleeping better, your appetite is better regulated, you don't feel sad about yourself all the time, but you still don't want to get out of there. We need to find out what are the factors psychologically and social that are preventing that person from taking the risk. Let me give you an example. This is actually a true case. A patient that I've saw for a long time, um, who was having typical symptoms of major depression: no energy, motivation, interest, suicidal thoughts, you know, lasting for more than 3 weeks, no suicide attempts, so she didn't require hospitalization. So we started on medications, right? And the symptoms got better and got better to the point that she was willing to take the risk of going back to work, right? So going back to work, but she will come to my office and tell me, I'm doing great, but I'm very unhappy at home, right? So then you have to ask, okay, what's going on at home, right? That is this person is fully functional, from the time she leaves home to the time she gets home. Then she goes into this sadness state. Not the typical classic symptoms of major depression, but unhappiness, not being content. And as we start looking into this, both myself and the therapist who was seeing the patient, I mean, we started to realize that she was in a domestic violence situation, right? So the stress of domestic violence precipitated severe depression in a person who was vulnerable because they had a family history of depression. But now she is partially outside of the bubble of misery but goes back to it at night, right? Because it's protected. So I had to be blunt with her, and I had to ask her, okay, because she wanted more try other medications, she wanted to change something, and I said, Um, how many pills would it take for your husband to stop being violent with you?
mm,
Now, she didn't like that because that was a very paradoxical way of approaching this. You can say it wasn't a very empathic way, but it did make her think, right? And to focus on the fact that you are in a bad situation that is potentially dangerous to you, and you're doing whatever you can to keep yourself safe, right? But you're very unhappy with this. Medications don't help with that.
mm,
They don't. I mean, if we have somebody who's in a domestic violence situation is depressed, it's going to help with the depression symptoms, but it's not going to make the other person stop doing what they're doing. So that's, you see, those are the factors that are important. It's like some people get depressed because they drink too much alcohol, right? Alcohol is a depressant. You drink too much to it, it's going to have an effect on your brain, and then they get upset, right? Uh, because you tell them you need to stop drinking and say, well, give me a medication for depression. Okay, here it is. And maybe some medication to decrease your craving for alcohol. And they get less depressed, but they don't stop drinking, right? So it is complicated because we're social beings, right? So we have to interact with the world. And sometimes depression becomes a tool of avoidance. And I'm not saying that just in a light way. What I'm saying is that when we're depressed, we have to protect ourselves,
mm.
right? I mean, we have survival skills. And think of it, you see, biologically speaking, we've talked about this before. Being depressed is like having the flu. If you really think about it, it's an inflammatory process too. So you're tired, you don't want anybody to talk to you, you're moody, you sleep too much, you sleep too little, you eat too much, you eat too little. So think about having the flu without a fever and having it for 2 weeks. That's major depression.
Mhm.
Okay. Everything starts feeling bad, everything is negative. You start thinking that your life is not worth living. So it gets pretty intense.
So you mentioned well, we talked about the biological side of medications, and then we have to look at the larger scale. But you mentioned risk factors. Are other than family history, is there any way for a person to see if they actually are at risk of potential? Because you said it's very possible for somebody to have these potential depressive tendencies, but until a trauma of some sort occurs, they may not come out.
Well, the the most important risk factor that is easily identifiable is having had depression in the past, right? So if you've had depression in the past, you're more likely to have depression in the future. That's pretty basic. But also, family history becomes terribly important, both for anxiety and depression. So we have to ask. A lot of people don't know. A lot of people don't know their family history. You
Mhm.
know, I mean, a lot of people don't talk about your uncle that in the 1950s blew his brains out in a suicide attempt and died, right? So because we didn't talk about those things. But there's nothing wrong with asking: is anybody else in the family suffering from depression? Is there anybody else in the family suffering from an ADHD? ADHD is one of the most genetically based mental disorders. It's actually not a mental disorder; it's a neurodevelopmental disorder
Mm,
because it has to do with the connections in the brain. But it's highly genetic. You know, if you have a child that has ADHD, there's like a 50 to 70% chance that one of the parents has it too. And not unusually, we diagnose kids, and then the parents want to come talk to us after we explain things, right? So genetics becomes terribly important, but temperament too. So if you're temperamentally intense, you're very aggressive, if you're easily angry, if you're frustrated, or you're temperamentally very cold and avoidant, you're more prone to having depression. Now, we cannot negate the importance of development, right? So, being abused as a child makes you more vulnerable to have depression as a teenager, as an adult, right? So, abuse, whether it's physical, sexual, and in my book, neglect is probably more painful and creates more of a risk for depression than abuse itself, right?
mm,
Because neglect, really gives you the message that you have no value. You're not important enough for me to pay attention to you. And in the life of a child, from the time they're born until they're teenagers, the most important thing for them is the recognition they get from their parents. So if you're not capable, you're not able, you're absent, you're drinking too much, you're getting high, and you don't have time for your kids, well, you're putting your kids at a risk for higher potential for depression too.
Well, as you've discussed, we've had all the different aspects of it. Depression is very maybe talked about a little bit flippantly, but obviously much more complex. Once again, thank you for your information. Everybody out there, please like, subscribe, and share. And feel free to leave comments down below and let us know what you want to talk about or hear more about. And we'll continue these shows, and we'll see you next week.
Hey Vince, thank you very much. Thank you very much to the audience, and we'll connect again next week. Thank you.
Take care.